Yes.
Good morning, sir. Today and tomorrow we will be looking at the Newcastle Haemophilia Centre. As with all presentations on haemophilia centres, this isn't intended to be the last word on the Belfast Haemophilia Centre. Rather, the intention is to explain and put into the public domain what contemporaneous documents that have been received and examined so far by the inquiry explain or reveal or suggest about the facilities, policies and practices at the centre. I'll also highlight at various stages aspects of what witness testimony has told the inquiry. You, sir, will recall the very powerful oral evidence heard in Belfast from individuals who had been infected or whose family members had been infected.
I do indeed, yes.
In addition to that testimony, the inquiry has, of course, received a number of other statements, again, from those infected or from their families, all of which have been read and considered by the inquiry before today. And I'll refer to some of the themes that emerge from those statements. In terms of clinical evidence, we have several witness statements from Dr. Elizabeth Maine, who is, you know, sir, will not be giving oral evidence to the inquiry, but we have her written testimony, as well as a number of earlier reports that she produced in the course of the late 80s or early 90s, and I'll be referring to those in some detail in the course of today and tomorrow. We have a statement from Professor Bridges, a statement from Dr. McNulty and a statement from Dr. Anderson, and we are also seeking statements from other clinicians. And you, sir, will decide whether to hear any oral evidence from any of those clinicians once you've seen such further evidence as, such further statements as the inquiry is able to obtain. We will be hearing on Thursday from a more recent perspective from Dr. Benson, the current Haemophilia Centre Director, and you'll recall in relation to the Cardiff Haemophilia Centre, we heard from Professor Peter Collins, who was in a similar position. Obviously, he cannot deal with the events of earlier decades, and we won't be asking him to do so. So that's by way of introduction. I'm going to start with an overview of the centre, its facilities and staffing and patient numbers. And we'll then turn to look in more detail at the products that were used and the treatment policies gleaned from a number of different sources. So the centre, the Belfast Centre, was established by Professor Nelson in 1958. It was located at that stage within the hospital's clinical pathology department. Seamus, if we go to RHSC 5067_002, please. This is a report from March 1988 called A Profile of the Management of Haemophilia in Northern Ireland. I'll come back to it at various stages. It's authored by Dr. Maine, and it appears it was a document addressed to the health authorities in Northern Ireland, exploring issues about funding of haemophilia care in Northern Ireland. For present purposes, if we go to the second page, we can pick up some information about numbers in the 1950s. Top of the page is a table. 1958, 44 patients with haemophilia A and 1 with haemophilia B. And Dr. Maine tells us in the sentence below the table, in the 1950s, no true hemostatic treatment was available. Bleeding episodes were managed with infusions of fresh frozen plasma. So that's a snapshot of the numbers in 1958. The available documentary and witness statement evidence suggest that remained the number of patients known to the centre during the course of the 1960s. There were no dedicated staff or inpatient facility for haemophilia care during that period, and no specific physical location for the centre according to the documents that we have. Now that's in terms of adult haemophilia care. In terms of paediatric care, children with bleeding disorders were cared for at the Children's Hospital. And Professor Bridges, who was the paediatrician in charge there until around 1979, has estimated in his statement that there were approximately 10 child patients with bleeding disorders prior to 1979. We can take that document down. Thank you, Shomek. We know from the various documents and statements that we have that the numbers of patients grew during the 1970s and 1980s, and the staff team also grew. So that from around the 1983, there was a part-time physiotherapist, a nurse, a secretary, and some social work input. And I'll look in a few moments at a document which has more detail of staffing in the 80s. The Haemophilia Centre in Belfast was not a reference centre for a number of years. And if we go to Hcda 40405, please. You'll see these are the minutes of a meeting of Haemophilia Reference Centre directors, 26th of February 1980. And if we go to page 6, under the heading Haemophilia Reference Centres in Scotland and Northern Ireland, we will see the question of the status of the centre being raised. Professor Blackburn said that patients had raised with him the question of haemophilia reference centres in Scotland and Northern Ireland. There were at present no official reference centres in either Scotland or Northern Ireland, and some patients were very worried about this. And then there's reference to a DHSS leaflet from the 70s from Professor Bloom, and reference to what was said to have been agreed in relation to Scotland. Picking it up a few lines down, we then come to Northern Ireland. Northern Ireland was included in the Oxford supra-region, and Belfast was the only haemophilia centre in Northern Ireland. After some discussion, it was suggested that Belfast should be regarded as the reference centre for Northern Ireland, and that Dr. Ritzer should write to Dr. Maine asking if she would approve of this idea and if she would like to attend future reference centre directors' meetings. This was agreed. It was also agreed that the Department of Health should be asked to put Edinburgh and Glasgow as the Scottish reference centres and Belfast as the Northern Ireland reference centre. We go to the top of the next page. In the list of UK haemophilia centres when this was reprinted. So we can take that down. So we can see the agreement there that Belfast should become a reference centre. One of the significant consequences of that was that from the point at which it was recognised as a reference centre, Dr. Maine was, as it were, eligible to attend the reference centre directors' meetings and would thus be privy to the information that was discussed and disseminated at those meetings from the early 1980s onwards. And we don't need to go to the document, but the minutes of a UK Hcda meeting from September 1981 note that a Dr. Thornton in the Northern Ireland office of the DHSS had written to Professor Bloom confirming that the centre at the Royal Victoria Hospital had been designated as a haemophilia reference centre. As that document recorded, there was only one recognised haemophilia centre in Northern Ireland, and it served patients drawn from all over Northern Ireland. There was a reciprocal arrangement with a centre in Dublin, which enabled some patients from the Republic of Ireland to attend Belfast for treatment, if that was more convenient, and Belfast patients to receive treatment in southern centres when in the Republic. And we can see that if we go to HSOC 0022947, you'll see this is a copy of the Haemophilia Society's Bulletin. This is a publication from 1989. Shomek, if we go to page 9, and if we look at the heading, the centre, so it's the second column, that's it, the first paragraph, the Northern Ireland Haemophilia Centre serves a population of 1.5 million. Its patients are drawn from all over the province, and a reciprocal arrangement is operated between the centres in Belfast and Dublin. This enables a small number of families from the Irish Republic to attend Belfast for convenience of travel, otherwise they would need to make a long and tedious journey to Dublin. In return, patients from the Northern Ireland Centre who go on holiday to the Republic of Ireland are treated free of charge at appropriate southern centres. We can see a question that arose about how that should be dealt with in financial terms from an exchange of correspondence between Dr. Maine and Professor Temperley from Dublin. Shemik, if we could go to BHCT 40623, please. We can see that in September 1984, Dr. Maine was writing to Professor Temperley about a particular patient. If we go down so we can see the text of the letter, and in the second paragraph, so it's a patient who had attended the centre in Belfast for treatment. It would appear whilst on holiday in the north. In the second paragraph, she says this: I enclose a total of the amount of factor 8 that he has received while in the north. And I suppose the simplest method of payment would be for your centre to send our centre the same amount in kind rather than involve our respective finance officers. So it would appear that Dr. Maine contemplated that concentrate from Dublin would be sent to Belfast as a payment in kind, rather than some form of a financial charging arrangement. But before we look at, next paragraph, she says, perhaps when we next meet, we might discuss this type of problem, as of course it will arise from time to time. If we just look at the last paragraph of that letter, you'll see reference to the Blood Club. And she says, I'm sorry, I will not be able to be at the Blood Club later this month, as I was already committed to a hemostasis meeting in London. And this appears to have been some kind of a gathering for Northern Irish and Irish clinicians to discuss matters relevant to haematology. It may have overlapped with or fulfilled a similar function to that which we've described as taking that which we've heard described taking place under the auspices of Professor Savage. It may be the same, it may be something different, or it may be something that performs a similar function. We've not got any further information at present. But returning to the issue raised with Professor Temperley, we can see his reply at BHCT 40622. He says in his response of the 10th of October 1984, I think it would be rather silly to charge each other for treatment of haemophilia during short visits north or south of the border. This should, in the ordinary course of events, balance out. On the other hand, I agree when prolonged treatment is envisaged for a citizen of the Republic in Northern Ireland, we should make suitable compensation as we discussed. Perhaps you might give the question of short visits more thought. And I won't go to Dr. Milne's subsequent letter, but she agrees that there's no need to charge for short visits. Whether there transpired any exchanges of concentrate in kind, as it were, for longer visits, the documentation doesn't tell us one way or another. Shemik, can we go back to the Bulletin article? So HSOC 22947. So HSOC 0022947. My apologies. And if we go to page 8. So we can pick up in the same article a little more information about the staffing arrangement. This is by the 1980s, late 1980s. We look at the heading staff. We can see this is the position by 1989. The permanent medical staff of the centre comprises 3 consultant haematologists, 1 the author, that's Dr. Maine, who has overall responsibility for province-wide haemophilic care, aided by the Professor of Haematology, Professor Bridges, and Dr. Dempsey, who carries responsibility for all paediatric activity in the centre. Sister Catherine Farrell is the sister in charge of the outpatient facilities. She is on the committee of the Haemophilia Nurses Association and is the present membership secretary of that organisation. She's ably supported by staff nurse Colette McAfee, In the ward, Sister Mary McGugan keeps a close eye on haemophilia inpatient problems. Both are members of the Haemophilia Nurses Association, as are many other ward nurses, making a total of 7 members at the present time. So that's nursing staff. In terms of physiotherapy staff, we learn in the next paragraph that in 1983, a part-time haemophilic physiotherapist was appointed initially, and for a further number of years she was funded by the Haemophilia Society. Mrs. Lynn Crockart has proven her worth time and time again. And then if we go to the next paragraph, we find details of dental care. A dentist there identified who has provided consultant dental care and runs a primary care clinic devoted to the management of patients with bleeding disorders. There's then reference to the various laboratory staff, the senior chief MLSO, Mr. Carville, who's said to have been in charge of blood product provision since the late 1960s when cryoprecipitate was prepared locally in the department. And then Dr. Maine continues, after the transfer of its manufacture to the Northern Ireland Blood Transfusion Service, he became in some respects what might be described as the keeper of the privy purse. He's never allowed the stocks of blood products to run dry, and he and his staff in the hospital blood bank are responsible for issuing all the material for home treatment. They maintain computerised records of the same, and indeed all treatment, a job important and so necessary for the compilation of the annual returns for Oxford. No haemophilia centre can exist without accurate laboratory tests to establish the diagnosis and to maintain monitoring of the effectiveness of the treatment given. And the chief MLSO, go to the top of the next page, Terry Ingalls, has been in charge of the coagulation laboratory for more than 12 years. More recently, new additions to the staff have taken place. And so we see reference in the next sentence to there being a permanent secretary for the Haemophilia Centre and a scientist. The next paragraph refers to the involvement of a professor of orthopaedic surgery. And then in the last paragraph under the heading staff, Dr. Maine picks up on the question of social work and says this: in the past, the Northern Ireland Haemophilia Centre was not overwhelmed by help or interest in terms of input from social workers. Some came and went, some showed interest, and occasionally when an excellent one was appointed, she had to leave having gained promotion. Others declared that the problems of haemophilic patients were insoluble. However, the picture during the past year has changed, and since the appointment of Miss Geraldine Kerr, the social worker is now closely involved and is rapidly making her mark in the centre and amongst the patients. So that's the picture in terms of staffing by 1989, and obviously at earlier stages, far fewer staff members. If we could then turn to BHCT 40503. You will see the date of the document at the bottom. It's the 1st of August 1985. That's actually the second page of the document, so if we could go to the next page, which is where it begins. This would appear to be a document authored by Dr. Maine. Certainly in terms of its look and style, it sounds like Dr. Maine. It's headed Northern Ireland Haemophilia Reference Centre Factor 8 usage. I'll no doubt come back to it when we look at blood product usage. But for present purposes, this provides an update of information about numbers of patients. The first sentence suggests that the centre became a designated reference centre in 1976. As we've seen from UK Hcda minutes, that would appear to be incorrect. But in any event, in the second paragraph, we then see the number of people registered in 1984/85 as suffering from inherited bleeding disorders, 189 people broken down as they're set out. So 124 with haemophilia A, 16 haemophilia B, 45 von Willebrand's disease, 2 with factor 10 deficiency, 1 with factor 13 deficiency, and 1 with factor 11 deficiency. And then we see in the paragraph below that, out of this number of patients, 63 are residential and drawn from the Eastern Health Board area. Some 25 of these originate from the North and West Belfast district. The remaining patients are equally divided between the other health boards, 43 from the Northern Board, 43 from the Western Board, and 40 under the aegis of the Southern Board. And she explains below that in order to simplify the treatment of these patients, all the blood products necessary for treatment are held at the reference centre and issued to other hospitals in the province, specifically designated for individual patients. And then I'll leave that document for now because I'll come back to what it says about products in due course. We have various further figures in relation to increases in patient numbers, and we can pick that up in terms of the modern picture and the picture over recent years from the evidence of Dr. Benson on Thursday. The article in the Bulletin, I won't go back to it, but it also shows a development of the physical facilities such that by 1989 there was a day centre and an inpatient unit with 16 designated beds, and Dr. Maine's article suggests that at least a quarter of those tended to be occupied by haemophiliac patients much of the time. There is also reference in the documents to a joint haemophiliac and orthopaedic clinic being held every 3 months by March of 1988, and we've seen reference in that article to there being a regular dental clinic. Again, just sticking with an overview of the facilities and services at the centre, if we go to LOTH 5051_089, we'll see a short document from January 1992. It's confidential to the Haemophilia Centre Directors of Scotland and Northern Ireland, and it's a report on clinical audit from 1991, and it sets out the results of clinical audit visits. If we look at the list of centres, Belfast was audited by Dr. Ludlam, and that's Centre 2. And if we look at the recommendations made by the auditors in the list below, for Centre 2, what Dr. Ludlam apparently picked up on his audit visit to Belfast in 1991 were issues about privacy of bedside and telephone conversations, and there's a suggestion of dedicated rooms and staff and a need for more social work and physiotherapy input. And if we look a little further down the page, the last section of the document says replies were received from patient questionnaires as follows. So it appears that the audit involved a patient questionnaire process. And for Centre 2, I don't know whether N equals 5 suggests that the number of replies received were 5. And it picks up upon those replies having suggested that HIV counselling by juniors...
the number of replies that dealt with the question.
Yes, you may be right. HIV counselling by juniors inadequate is what's picked up there. And we can see...
yes. Before you pass from that, it's interesting that while Professor Ludlam was auditing Belfast, Dr. Maine appears to have been auditing Glasgow.
Yes.
And the comments critical of Glasgow appear to include that it needs counselling rooms, which is very similar to the criticism which Professor Ludlam is making of Belfast.
Yes. Yes, you're right, sir.
Which is interesting.
If we go to Dr. Maine, a document authored by Dr. Maine, which sets out a reflection on the audit. It's at WITN 0736010. It's described as a 1991 report of activity of the Northern Ireland Regional Centre for Hereditary Haemorrhagic Disorders. And if we go to page 6, we can see under the heading Haemophilia Clinical Audit, Dr. Maine says this: the Haemophilia Clinical Audit was completed during the month of August 1991. It was carried out by Dr. Christopher Ludlam from the Regional Haemophilia Centre attached to the Edinburgh Royal Infirmary. All the facilities at the centre in Belfast were examined, and a signed copy of his report is attached to this document. He's indicated clearly the areas which he regarded to be significantly deficient. The most important lack of facility is an area where the patients can be seen in privacy and confidentiality. This is particularly relevant to those patients who are HIV positive. The second deficiency was the lack of a dedicated social worker to all the haemophilics in the province. Due to the widespread distribution of patients and families within the region of Northern Ireland, it has always been a sad lack that there was no facility for a peripatetic social worker who could carry out the appropriate home visits. It is hoped that this will be rectified within the near future. And it's a report dated, if we just go a little further down that page, 9th of July 1992. So although the article in the Bulletin in 1989 had expressed a degree of optimism about the provision of social work, by that stage at least, it would appear that the position had not been satisfactorily addressed by 1992.
I don't quite understand the reasoning there. It is obviously true of Northern Ireland that there will be a widespread distribution of patients and families if you have one treatment centre covering the whole of Northern Ireland. But because of that, it said, it's always been a sad lack there is no facility for a peripatetic social worker. It's saying because you've got space to go to, places to go to, there's no facility for someone who goes to places. I don't understand the logic.
I can't cast any further light on it, sir. I see your point. But that's what we have about it.
Yes.
It appears that there was an ongoing lack of such provision, and indeed of the other facilities identified in the audit and referred to here by Dr. Maine. I
mean, I would have thought the reasoning won't be a question of distance from centre to home, but a question of funding.
Yes. Yes, or possibly difficulty of recruitment. I don't know.
Well, it may be. I mean, I suppose if people are spending their time travelling rather than actually working, there may be questions asked by finance. It may be that may have been the reason for it, but still, that's what we see.
It is, and we know that by this time, it's the same document. Let me just get the page. Yes, if we go to the first page, just to get an update of numbers, we can see it says the category. This is the third line. The categories of patients which were seen are as follows. So this is not patients simply registered, but patients seen. And then it says registered numbers shown in brackets, but there aren't brackets, so I'm not quite sure what that refers to. But in any event, Haemophilia A, 147, Haemophilia B, 14, von Willebrand, 61, symptomatic carriers of Haemophilia A, 7, and then inherited platelet disorders, 24, and then reference to further clotting disorders and blood disorders as set out there. So I think that probably is the number of registered patients.
Well, if so, it's gone up by about 100 from 1985.
No, from an earlier period. I think with the figure we've... Oh, no, you might be right, sir. Yes, there were 189 in total in 1985.
And this is 92, so 7 years.
Yeah. In the early 2000s, 2001, 2002, haematology services at the Royal Victoria Hospital were amalgamated with the City Hospital, and the centre moved from the Royal Victoria Hospital to the Belfast City Hospital. The arrangements for the move and a comparison between the available facilities is set out in some detail in the statement of Dr. Julia Anderson. And Dr. Benson may also be able to provide some information about the current arrangements in his evidence on Thursday. That's adult care. In terms of when children transferred from paediatric care to adult care, if we look at Dr. Maine's evidence, it's WITN 0736006. And we go to, this is a statement of hers from February 2020. If we go to page 5, paragraph 22, and we look at the last sentence, she says the transfer age to adult care at the Royal Victoria Hospital was 13 years of age. Professor Bridges' statement is at WITN 4569001. And if we go to the third page, he gives an age of around 14, but says there were no hard and fast rules. So he says, at the children's hospital, so that's the Royal Belfast Hospital for Sick Children, I was responsible for the care of patients with haemophilia and related disorders, as well as children with leukemia and other blood disorders. Children with haemophilia would have been looked after in the children's hospital up until the age of around 14, before transferring to the adult hospital, the Royal Victoria Hospital, although there were no hard or fast rules and no formal process for transferring to the adult haemophilia service. And he does indicate, and I'll come back to this part of his statement in a little while, he does indicate that there might have been children who were transferred at a younger age to the care of Dr. Maine if he thought that they might need to be treated with factor concentrates, because he used only cryoprecipitate, and anyone who needed treatment with factor concentrates would be dealt with by Dr. Maine. Again, Dr. Benson will be able to tell us what the current position is in terms of the transition from paediatric to adult services. So we can take that down, thank you. So just dealing a little more with the various doctor names that we see crop up from time to time in the material, or in the case of Dr. Maine, we see crop up frequently in the material. Dr. Elizabeth Maine trained in Belfast. She worked as a senior registrar in haematology at the Royal Victoria Hospital from 1968 to 1972. She completed her MRC path in 1970, became a consultant haematologist in 1972, and she remained at the Royal Victoria Hospital Belfast throughout her career until she retired in 1999. She was the director of the centre, taking over from Professor Nelson from 1978 until her retirement in 1999. Dr. Maine was also a member of a number of different committees and organisations. She was chair of UK Hcda in the early 1990s. She was a trustee of the Macfarlane Trust and the Eileen Trust for a period of time in the 1990s. She was at some stage vice president of the World Federation of Haemophilia, and I think also in the early 1990s she was participated on the Committee on the Safety of Medicines. We have 6 witness statements from Dr. Maine. 5 are statements responding to a range of individual witness statements from patients or former patients and their families. Her 6th, the most recent statement, is a long statement in response to the broader general questions posed of her by the inquiry. We also have, as you've seen already, some various miscellaneous documents authored by her, and then a lengthier expert report that she produced in 1990 for the HIV litigation, presumably at the request of the Department of Health. In terms of other clinicians, I've made reference already to Professor Bridges. He was consultant clinical pathologist at the Royal Group of Hospitals in Belfast and based at the Royal Belfast Hospital for Sick Children, and as we've seen, responsible for paediatric care for those patients with bleeding disorders who were children until 1979. In 1979, he was appointed chair of haematology at Queen's University Belfast, and his statement indicates he spent 50% of his time thereafter in clinical practice and worked at the adult hospital, primarily in leukemia and general blood disorders, and his only involvement with adult haemophilia care, he says thereafter, was to provide cover for Dr. Maine. His role at the Children's Hospital was taken on by Dr. Dempsey, and Professor Bridges then retired in 1994. There's also Dr. L. Agnaf, who worked as a registrar in haematology at the Royal Victoria Hospital for a period of just under a year, August 82 to July 83, and then worked at the City Hospital. He worked in the blood transfusion service for a period of time, and then again at the Royal Victoria Hospital. And in January 1988, became an acting consultant haematologist at the Belfast City Hospital. Again, however, his role appears to have been predominantly in relation to more general haematology. Dr. McNulty worked in the Hemophilia Centre from 1992. She was a staff grade doctor from 2000 and an associate specialist in 2008. Dr. Frank Jones was the acting director of the Haemophilia Centre upon Dr. Maine's retirement, and he was acting director from 1999 to 2001. In 2001 or thereabouts, Dr. Julia Anderson became full-time haemophilia consultant and director at the centre. She was there until around 2005, and then Dr. Jones seems to have taken up the mantle of acting director again until Dr. Benson's employment. There was also a brief interlude in which there was a Dr. O'Keefe as consultant in 2006. I'm going to turn now, having given that overview of the centre facilities and staffing, to the use of blood products. We've seen a passing reference to in the position in the 50s, treatment with fresh frozen plasma. Prior to the advent of factor concentrates, it's clear that the product of choice was cryoprecipitate. And I want to look at what both Professor Bridges and Dr. Maine say about cryoprecipitate. So we'll start with Dr. Bridges and go back to his statement at WITN 4569001. And if we go to page 5, sorry, page 3, my apologies. So under the heading Roles and Responsibilities at the Children's Hospital, we've looked at the first paragraph already in terms of age of transfer. In the second paragraph, he says this: during my time at the Children's Hospital, the main treatment for children with haemophilia was cryoprecipitate. There was no register of patients as far as I can remember. I do not recall having any child patients who would have been under the ages of 5 to 7 approximately, although I cannot be certain. Cryoprecipitate became available around the mid-1960s. This was a major development in the treatment of haemophilia. Prior to the introduction of cryoprecipitate, treatment would have been limited to measures such as bed rest and pain relief and so on. And then in the next paragraph he says, because my clinical experience of treating haemophilia patients involved mainly treatment with cryoprecipitate, a child who I considered might require treatment with factor concentrates would have been referred to the adult hospital to be seen by Dr. Maine. If we go over the page, if we look at the very bottom of the page, you'll see a heading Selection and Purchase and Use of Blood Products, in particular factor concentrates. And we go to the top of the next page. He says at the top of that page, when I was at the Children's Hospital, concentrates were not used. We used cryoprecipitate, which to the best of my knowledge was supplied by the Northern Ireland Blood Transfusion Service. And then he refers to the position at the Royal Victoria Hospital, where he spent some of his time after 1979, but essentially says he was not involved in decision-making about what products to use, either generally or in relation to individual patients. If we go to the next page, we can see at the top of the page, he says, when I was at the Children's Hospital, concentrates were not available. We used cryoprecipitate. There was nothing else, so the question of advantages or disadvantages did not arise. And then he comments, although I did not use concentrates, I know they were much more effective. They were also much more convenient, especially for home treatment. Cryoprecipitate had to be frozen. You needed space to store it, and so on. Back then, people did not have freezers that could accommodate it. Another disadvantage of cryoprecipitate was that it could not be used for surgery because you would not have had the level of cover needed. In fact, there's evidence it was used for surgery and did provide an effective level of cover, but that may not have been the case, obviously, for paediatric patients. And he again confirms in the paragraph below he wasn't involved in deciding on the use of concentrates as opposed to cryoprecipitate or in formulating policy regarding home treatment. So that tells us probably comparatively little other than cryoprecipitate was the product of choice at the Children's Hospital throughout the 1970s. In terms of the Dr. Maine's perspective on cryoprecipitate, if we go first to RHSC 5067_002, we looked at this a few minutes ago. This is her March 1988 report. I want to pick up first of all what she says in the first paragraph. She refers in the second line to the Birch paper about life expectancy of a severe haemophiliac in the 1930s, and then says this: new treatment in the late 1960s, which can only have been cryoprecipitate, not concentrates, and the innovation of a home care programme in the early 1970s. Pausing there, the evidence in relation to Belfast is that home treatment was introduced either in 1974 or 1976, but certainly the mid rather than early 70s. Increased the life expectancy to 71 years in 1977. She doesn't say where she gets that figure from, but if that's the life expectancy by 1977, logically it would seem that must, in large measure at least, be due to either to cryoprecipitate and not solely attributable to factor concentrates, because the evidence suggests that cryoprecipitate remained in active use for much of the 1970s. If we then go over the page and pick it up under the heading treatment, Dr. Maine says this: in 1967, a milestone occurred. A revolutionary concentrate was produced called cryoprecipitate. It was prepared from single plasma donation according to the methodology discovered by Poole, 1965. It was prepared initially in the Haematology Laboratory, Royal Victoria Hospital. Then the process was scaled up and taken over by the Blood Transfusion Service. No donor screening program existed for the detection of viral hepatitis, and many recipients developed clinical or subclinical hepatitis B. Nonetheless, the patients were ecstatic about the new treatment. A simple dental extraction was normalised and no longer constituted a major ordeal necessitating many weeks in hospital. And then if we go to the next page, she says, during 1971, cryoprecipitate was replaced gradually by commercially produced freeze-dried lyophilized factor 8. Again, we'll look at the returns, which show that in fact, some continuing usage for cryoprecipitate. It had a higher purity and a predictable potency. It became the routine treatment for severely affected patients, cryoprecipitate being reserved for mildly affected patients and those suffering from von Willebrand's disease. Thereafter, from 1974, so that's the date given here for the commencement of home treatment, the patients were encouraged to learn to treat themselves. This was to reduce or eliminate the endless hospital admissions. And then if we go down a couple of lines, she says, within 10 years from commencement, all patients with adequate vein access and who had passed successfully the 3-month teaching programme were placed on home treatment. The benefits accrued from this were as follows, and then she sets them out. In particular, hospital admissions becoming a rarity, and improved ability to attend school regularly and maintain further education. So
when it says within 10 years from commencement, it means by about 1984?
Yes, I think that's what this document is suggesting, yes. So that's her March 1988 report, produced, I think, for, as I say, for the purposes of trying to secure further funding. If we then go to CBLA 5072, _024. So this is Dr. Maine's expert witness report regarding HIV litigation, dated May 1990. If we turn to page 6, we can pick up about 4 lines down Dr. Maine's observations on cryoprecipitate. She says this: earlier in 1954, Professor Gwyn Macfarlane had defined the goal of treatment of a haemophiliac with factor VIII as continuation replacement, as in the treatment of diabetics with insulin. Factor VIII availability as cryoprecipitate transformed haemophilia treatment. It did not achieve Macfarlane's goal, but the crippling childhood deformities, the pain, the constant fear of death from trivial injury, and the further fear of bleeding following dental extractions or emergency surgery receded. Cryoprecipitate was and is prepared by the simple methodology of rapidly freezing donor plasma followed by slow thawing. Its factor VIII content is variable, as donor plasma levels have a wide range of normal within the population, and she sets out the range and sets out what on average a single donation of plasma will produce, so on average between 70 and 100 units of factor VIII. If we just go down a few lines so we can see the rest of the page. Picking it up with the sentence, in time experience using cryoprecipitate established that many donations were needed for the treatment of severely affected adult patients. The quantity required led to infusions large in volume and high in protein content. And then if we go, she says at the bottom of the page it also contains the factor VIII requirements for treating the bleeding of von Willebrand syndrome. Go over to the top of the next page. She then sets out reactions to treatment. So reactions to treatment occurred, probably related to the extraneous protein present. The adverse reactions included the development of skin rashes, minor chills, fevers, and on occasions more severe anaphylactoid responses occurred associated with difficulty in breathing and a lowering of blood pressure. Reactions also occurred when small volumes were infused, but in general, the mildly affected the children and the patients with the von Willebrand syndrome were treated with less complication. A major disadvantage was the unpredictability of infused dosage. Efficacy was assessed clinically and retrospectively in regard to achievement of factor VIII level in the patient. Maintenance of the sterility of each donor pack precluded estimates prior to infusion. A further disadvantage was the necessity of storage of the product within a deep freeze unit. So those are what are said to be disadvantages of cryoprecipitate. Advantages were efficacy, low donor exposure, safety, and simplicity of manufacture. There are pieces of correspondence, we've referred to them in our note on the centre. I'm not going to go to them now, but the references are in paragraph 30 of the note, which show cryoprecipitate being used in individual cases in the course of 1974. If we then look at Dr. Maine's witness statement, and we go to WITN 0736009, so this is her most recent statement, 4th of February 2021. If we go to page 6, first of all, Shomik. So I'm just going to pick up references to cryoprecipitate here. So paragraph 5.3, second paragraph on the page. The late 1960s was a special time for haemophilia. Cryoprecipitate, the first really effective treatment, had been discovered by Poole and Shannon in 1965. My fellow registrar, Dr. Brian Ottridge, initially was responsible for preparing in-house cryo within the hospital blood bank. He took up a consultant post in Dublin in 1968. I took over his mantle until the preparation of cryo was transferred to the Northern Ireland Blood Transfusion Service for production on a larger scale. So cryoprecipitate initially produced in-house before being taken over by the transfusion service. We don't, I think, have a date for when the preparation of cryoprecipitate was transferred to the transfusion service. But elsewhere in her statements and documents, Dr. Maine makes clear that there was never a difficulty in terms of obtaining sufficient quantities of cryoprecipitate from the transfusion service. And then if we go to page 11, I think, we can see at paragraph 10.1, she essentially confirms Professor Bridges' evidence. She says, in the 70s, apart from myself, no other individual was concerned with the selection and purchase of factor concentrate. Cryoprecipitate remained the treatment of choice for children. The then paediatric haematologist, no doubt Professor Bridges, rightly declined involvement in discussing the selection of products for adults. And then if we go to page 15, obviously come back to what she says about factor concentrates, but she talks about cryoprecipitate further in her statement as follows. She says this, when planning for home treatment with concentrates, I was anxious and apprehensive about repeatedly injecting patients with any material, particularly over periods of weeks and months via the intravenous route. Therefore, I decided that all children should remain on treatment with cryoprecipitate. This was early in the 1970s, and Dr. John Bridges, the paediatric haematologist, was happy with the decision. Later in 1982, his newly appointed successor, Dr. Dempsey, was even more enthusiastic about using cryo in this way than myself. However, we agreed an exception should be made in respect of a very limited category of patients, so this is still dealing with children. And in the next paragraph, she says this, in addition to the 2 severely affected paediatric patients already on home treatment, it was decided that patients with brain injuries or those who required major surgery should have definitive amounts of factor VIII concentrate to guarantee the achievement of 100% 8C levels. Fortunately, the situation never arose and concentrates were never used in those circumstances during my time. So, as is apparent from elsewhere in her statements, there were 2 child patients on home treatment with factor concentrates. The remainder of children, because no other exceptional circumstance arose, remained on cryoprecipitate. Under the heading below, why cryoprecipitate for children, she says this, due to their diminutive size, children did not require large doses of cryoprecipitate to be effective. This reduced the likelihood of allergic reactions, which were common in adult patients who did require larger doses. There are a number of problems associated with using cryoprecipitate in large doses. And then she sets out her perception of disadvantages of cryoprecipitate. Firstly, the inability to make reliable dose calculations. This was a very significant problem. Factor VIIIC clotting activity has a wide physiological variation. It can increase along with other clotting factors 4-fold during the 3rd trimester of pregnancy. Likewise, it's raised taking the oral contraceptive pill. It's also increased at ovulation, the mid-cycle of the menstrual period. This is probably designed physiologically to aid ovulation. Thereafter, the level falls again prior to the onset of menstrual bleeding. Exercise, particularly circuit running, is also associated with the doubling or trebling the factor VIII clotting activity on a temporary basis. It's likely due to increased blood flow through the spleen. Thus, there is wide variation in the 8C activity from batch to batch of cryoprecipitate dependent on the status of the donor. So that's Dr. Maine's explanation about reasons why there might be variations in the amount of factor VIII activity in individual batches of cryoprecipitate. Her second identified disadvantage is a purity issue. There's a purity issue due to the presence of incidental material, and she explains that during the time she was involved in the preparation of cryo, technicians noticing packs which had an odd colour, and suggests that those might be changes due to the oral contraceptive pill or donors using self-tanning sprays and lotions. She then says, thirdly, allergic reactions occurred in some patients. Reactions were mild, such as an itchy rash, but others were more alarming clinically, with temperature rises and rigours often lasting several hours. Fourthly, its preparation for use and its administration are relatively time-consuming and inconvenient. A fridge freezer is necessary for safe storage. Generally, patients prefer other forms of treatment. And then her fifth identified disadvantage is, like all untreated blood products, it carries the risk of viral infection. I should say that the question that was posed to her was a question to identify the advantages and disadvantages of alternative treatment. She set out there in relation to cryoprecipitate disadvantages, but not added anything in relation to what might be thought to have been some of the advantages of cryoprecipitate. So that's Professor Bridges and Dr. Maine on the use of cryoprecipitate. I'll turn next then to the evidence about the use of factor concentrates. If we go to BHCT 40784, this is a document about an individual case. It's dated the 12th of February 1970. And if we go down to the text, we can see it's from Dr. Maine to a Dr. Wallace. Picking it up in the second line, it says, in view of the importance of this knee joint to the patient's everyday life and well-being, and in consideration of the fact that he had received no cryoprecipitate for at least 1 year, we decided to treat him with factor VIII concentrate on this occasion. I raise that because it's the first documented usage of factor VIII concentrates that we found, February 1970. It's right to note that other documents suggest that the caution in relation to this particular patient about using cryoprecipitate was because of previous reactions to cryoprecipitate and concerns about inhibitor development, rather than any concern specific to either, rather than any issue relating to factor concentrates. So that's what we've seen as the first documented use of factor concentrates. I think elsewhere in the material, Dr. Maine in her statement suggests that the first usage was in November 1971, but she may well have understandably forgotten this particular incident.
Well, she may also have been referring in the latter to commercial concentrates.
She may.
Imported, then it would have to be on a named patient basis.
Yes.
And there's no suggestion in that letter that this patient had it on a named patient basis. So presumably, it must have been some of the BPL product such as it was at the time.
Yes.
Lister product.
Yes, I don't think we... No, I'm just looking at an earlier letter we have about this particular patient, but I don't think it tells us anything in terms of what the source of the concentrate would be, but that would seem to be right, sir, given the date. That's the earliest usage we've identified from the documents in terms of factor concentrates. If we go back to Dr. Maine's witness statement, WITN 0736009, and if we go to page, WITN 0736009. We go to page 11. And we can pick up in paragraph 10.2 Dr. Maine's recollection in her recent witness statement of the first use of concentrate. She says the first use of concentrate in Belfast was in November 1971. Haemophilic was admitted with severe intestinal bleeding, copious amounts of cryo were ineffective. It was impossible to stop the bleeding. He developed a high-responding inhibitor. It negated the effect of his treatment. And then she refers to having, earlier that month, spent some time in the United States doing research at Brown University, and then in Boston having seen the new factor VIII concentrate being used most effectively. She says she was impressed and brought this information home. Thus, my senior colleague, Dr. John Bridges, recalling this information, suggested I speak to my colleagues in the USA to see if any of the new concentrate could be procured for this young man. I duly made contact. I arranged for a consignment of Hemophilia manufactured by Travenol Laboratories Limited to be sent to Belfast. Coincidentally, on that very same day, Professor Ilse Ingram from St Thomas's in London had an identical problem. The company agreed to double the consignment to the UK. The product arrived in Belfast that evening. After treatment, the bleeding stopped. The patient remained well until discharge. And then she says this: thereafter, Hemophilia was the only commercial concentrate in use in Belfast for the next 3 years. if we, and I'll look at some more documents about Hemophilia and other products in a moment, but if we turn, before we do that, to CBLA 40187, these are the minutes of what's described as a joint meeting of directors of haemophilia centres and blood transfusion directors held at the Regional Blood Transfusion Centre in Sheffield, 31st of January 1974. If we go to the top of the next page, we can see that beneath Dr. Maycock's name, we see that Dr. Maine was there representing Professor Nelson at Belfast Haemophilia Centre. And then if we go to page 6, we just see a contribution by Dr. Maine to a discussion about, under the heading, a broader heading of the present and future supply of factor 8. Under the subheading, how much material was likely to be needed, we see recorded this. Dr. E. Maine gave statistics for Belfast and said that they use material prepared from approximately 10,000 donors for the management of their patients. They keep a stock of commercial concentrate, which they find invaluable in the present troubled times. What the troubled times specifically refer to is not clear, but there's information about both keeping a stock of commercial concentrate and pool sizes, as at 1974.
Yes, the pool size, it doesn't say whether it's NHS or commercial, but given the scale of that looks very much like commercial.
It does.
And that was her understanding at the time.
Yes, precisely. Now, that's the evidence we have about the introduction and early use of factor concentrates. In terms of which particular concentrates were used over the following years, I'm going to look first of all at Dr. Maine's statements and reports and then look at the contemporaneous documents. So if we start with one of her witness statements, it's WITN 0736006. This is her statement of the 21st of February 2020. And if we go to the second page, and we pick up in paragraph 5, the bottom half of the page, I'm going to pick it up in the second line. The Northern Ireland Blood Transfusion Service did not have the capability to manufacture concentrate. It provided local volunteer-derived single donation cryoprecipitate. Therefore, in the mid-1970s, when I initiated a home treatment programme, HT, for severely affected patients, commercial factor concentrate had to be used. The following policy for the Northern Ireland Haemophilia Centre was drawn up by myself and is as follows. 1. All HT, so home treatment patients, would be treated with only one product, Cryoprecipitate, immunolimited Vienna. 2. All non-HT patients would be treated with Hemophilia, Travenol Laboratories USA. 3. All children would continue to be treated with cryoprecipitate. There were 2 exceptions, namely 2 severely affected children who were entered into the HT, so home treatment group. There's then an observation that no child became HIV positive in Northern Ireland, and I'll come back to that when we look at the scale of the infections. Paragraph 6, at the time there was little scientific basis for the preceding policy, merely my innate apprehension about injecting material repeatedly and at frequent intervals by the intravenous route into young patients. At the time, I used what I considered to be the best and safest product for those patients who logically would need/use the most factor, namely the home treatment group. I selected Cryoprecipitate because I found the company businesslike, straightforward, and their packaging was ideal. Now, none of those factors would go to safety. She then says, however, incidentally, which might tend to suggest that it wasn't a primary motivating factor in her mind, the source of their donors was within Europe. The second product for the non-HT patients, so patients receiving treatment in hospital essentially, was Hemophilia, with which I'd been familiar for several years from 1971. In summary, the products used within the centre was as follows: A, HT group, so home treatment group, Cryoprecipitate Immuno; B, non-home treatment group, Hemophilia, Travenol Limited USA; C, children, Cryoprecipitate, manufactured by the Northern Ireland Blood Transfusion Service. However, demand exceeded supply within the home treatment group. The patients found that using the prophylaxis resulted in a normal lifestyle. UK-wide knowledge of good results in Northern Ireland plus increased demands resulted in Immuno being unable to fulfil Northern Ireland orders. Therefore, a further supply of Factor VIII was obtained from Armour Pharmaceutical Limited USA. In later years, when heat-treated product became available, supplies were received from SNBTS and Elstree. In fact, there's evidence of supplies being received from SNBTS pre-heat treatment, which I'll come back to. No supplies were received from the Republic of Ireland. So that's that witness statement. If we then go to her more recent...
Just
yes.
Pausing there. She makes a comment there about cryobuline and the source of the plasma. Now, we know from other sources that in the late 1970s, Immuno were offering cryobuline manufactured from two different plasma sources, one USA plasma, the other from European plasma. And the difference being that the European plasma cost more, the implication being that it was less likely to be infective with the hepatitis virus. So it'd be interesting to know what particular period of time Professor Maine, Dr. Maine, is talking about. She doesn't say, does she?
She doesn't know.
This is a very broad overview written looking back.
It is. We do have a number of the annual returns, not all of them, but they do help build up a picture, and I'll come on to those.
Thank you.
But Dr. Maine does not address that, you're right. If we then go to her most recent statement at WITN 0736009, and we go to page 12, we can see she's been asked what the reasons were that led to the choice of one product over another. She says cryobuline was chosen, so this is the top of the page, as the most suitable product for home treatment patients for a variety of reasons. And then she gives reasons in the next paragraph. Firstly, the packaging had been well thought out by the company. It was eminently suitable for all patient requirements to enable an injection to be prepared and administered with ease. All components were available and presented with clear instructions, right down to the Mr. Men plasters, the latter amused the adults. The company personnel were businesslike and efficient. So no reference there to donor source as a factor for the choice, or any different perception in terms of safety. And then she says in the next paragraph, the only concentrated use in the centre previously was Hemophilia. That company had no home treatment package and did not wish to increase their commitment to Northern Ireland. Therefore, the centre's treatment policy was as follows: Cryoprecipitate for children, Hemophilia for all non-HT patients, cryobuline for all HT patients, thereby attempting to minimise donor exposure in each group. There was no crossover of usage between groups. This is a most relevant point. So in addition to telling us which products were used, it would appear from this that a part of Dr. Maine's policy was to keep patients on one product. The extent to which that was successful or not is unclear, because certainly annual return information suggests that there were a number of patients who received a range of different products, and we'll look at that in due course. But that's what she says the policy was. And then she continues in paragraph 10.8, furthermore, the number of companies that would need to be dealt with was also minimised, just in case of any mishap or complication that might occur. Always I had concerns regarding the repeated injections of IV material in relation to the risk of as yet unknown viruses being transmitted. She then, if we just look further down...
Just
yes.
pausing there. Earlier, just a few moments ago, you were showing me a document which said there was no scientific basis for the regime which he adopted. He's now setting one out.
Yes.
Yes.
We then see paragraph 10.9. She says, it was difficult in the early days to estimate the quantities of concentrate required, particularly for home treatment patients. I came to the conclusion that these patients would require amounts double or even treble after their first year of treatment. It seemed likely that patients would change from using treatment to stop a bleed when it occurred to taking treatment to prevent a bleed occurring. Each patient would develop a particular pattern of prophylaxis to suit his lifestyle. This scenario did occur. The expected increase in demand for concentrate developed. Therefore, it became necessary to meet frequently with both companies to plan and adjust standing orders to obtain discounts for the increased quantities in use and to ensure continuity of availability. During the late 1980s, and that I think is an error, and it's not consistent with what she says elsewhere, a third product had to be introduced due to increased demands for cryoprecipitate, creating a significant shortage. Armour Pharmaceuticals made a successful tender and became the provider of the third product.
If only one company was being used for home treatment, then I don't understand the logic of what her comment in 10.9 became necessary to meet frequently with both companies to plan and adjust standing orders when the reason for the increase has been home treatment demand.
Yes.
Yes.
I can't offer an explanation, sir. You're right to identify it doesn't entirely add up in terms of reasoning. And as I say, the date of late 1980s, I'm fairly confident, is incorrect in terms of needing to resort to armour. So before we break, just one other document on this theme. There are quite a lot of documents, important documents to look at. This is RHSC 5067_002. So this is the same March 1988 report that we've looked at already on two occasions. If we go to page 4. Bottom of the page, she looks at HIV, numbers of those infected. I'm going to come on to that this afternoon or tomorrow. But I just want to pick up what she says about policy, last 4 lines on this page. The figures may be explained on the basis of the transfusion policy operated in the Hemophilia Centre since home treatment began in 1974. A single commercial product was used for all home treatment patients, and a second product was used for the rest. Thus, patients were exposed to a regular and restricted number of donors. It is probable that exposure to many different commercial products resulted in the higher positivity rates in other centres. Well, actually, I'll just read the whole paragraph, I think. Despite using the same quantity of factor 8 per patient per year, the Northern Ireland positivity percentage is equivalent to that in Edinburgh, which only used local material from the blood transfusion service and at no time used commercial concentrates from whatever source. In addition, all the severely affected patients in Northern Ireland were placed on product A for both home treatment and inpatients. And pausing there, that doesn't appear to be right when we look at the data submitted to Oxford. It so happened that this product was of European origin, which became contaminated at a later date compared with American products. It is likely this caused the smaller number of positivities in the province. And then that's said to be hopefully a saving for the future, as there'll be fewer patients who develop the full-blown acquired immunodeficiency syndrome. So that was her evidence in 1988. I say evidence, her report in 1988 about the treatment policy. I'm going to come on to various other documents, in particular contemporaneous documents, but perhaps we could do that, sir, after the break.
Thank you. We'll take a break then until 11:45.
Thank you, sir.